All right. Hi, everybody. My name is Dr. Kim Dennis, and I'm going to go ahead and get us started here right at the 12 o'clock Eastern hour. And I'm very excited to have invited Dr. Rachel Woodson Goode to give a grand rounds today with a free continuing education and continuing medical education credit to speak with us about eating disorders in Black women and to share her expertise and research with us. I'll tell you a little bit about myself. I'm the co-founder of Suncloud Health, who is sponsoring the educational series. And my husband and I started it back in 2017. I'm an adult psychiatrist, and I specialize in treating eating disorders, addiction, and trauma. And we've been able to offer both residential and PHP, IOP, and outpatient care to patients in the greater Chicagoland area. We have a specialty residential unit specifically for co-occurring eating disorder and addictions, and then another residential unit for primary mental health, addiction, and or eating disorder. And we have adult and adolescent programming, and we also offer interventional psychiatry with TMS and esketamine. For the purposes of obtaining your CEs, or if you have other questions, I've had Sal on my team here put in the chat the email address for Tammy Gazer, who is a coordinator here to help people who have questions around getting their CEs. And now I'm going to go ahead and introduce Dr. Rachel Goode, who is an associate professor at the School of Social Work and an adjunct assistant professor at the Center for Eating Disorder Excellence, Department of Psychiatry at the University of North Carolina, Chapel Hill. Dr. Goode received her PhD, MPH, and MSW from the University of Pittsburgh. Her research interests include developing, implementing, and evaluating equitable and community-engaged interventions to treat obesity and eating disorders. Her research has been funded by the National Institute of Health, the National Eating Disorders Association, McGee Women's Research Institute, and the University Research Council at UNC Chapel Hill. Currently, Dr. Goode is the principal investigator at an NIH Career Development Award, K23, to develop a culturally relevant digital health tool to treat binge eating and obesity. Additionally, Dr. Goode is a licensed clinical social worker and has practice experience with the treatment of eating disorders and obesity among clients in university counseling centers and community-based mental health agencies. She's been fortunate to be the recipient of various awards, and I'm sure many rewards, including Oprah's Civic Leadership Award, the Deborah Paget Early Career Scholar Award, and the Outstanding Dissertation Award from the Society of Behavioral Medicine. So without further ado, welcome and thank you so much, Dr. Goode, for being here. I'm very excited to hear your talk. So I'm going to go on mute, and then at 12:15, we will have 15 minutes of question and answer. So please, please, please use the chat and the Q&A button on your Zoom to get your questions in there so I can share them with Dr. Goode at the end. Thank you.
Thank you so much for that introduction, Dr. Kim. I am so grateful to be with the Suncloud community. Thank you all so much for attending today. And yes, so I encourage you all, please do talk to me. I don't want to talk to myself. So I'm just looking forward to us having just a robust time, just sharing and learning from one another. So as Dr. Kim said, I am faculty at UNC, but one of my most favorite roles is that I am the director of the Living Free Research Lab. And in my lab, we have spent the last 7 years really trying to build out what we know about how to help those who have been underserved, particularly Black Americans and those in poverty. How can we help improve our treatments for disordered eating, understand the factors affecting their eating behaviors, and really begin to broaden our knowledge on what disordered eating looks like in these populations. I am also a key content expert for the National Center of Excellence for Eating Disorders. If you all aren't familiar with it, it's a great training resource, and we really are just kind of trying to be on the front lines at providing opportunities for training, particularly because we know how not having training in eating disorders can really cause harm for our patients. And so we have a number of different training opportunities. And so I have been able to just offer trainings for folks all across the country as they're trying to learn more about disordered eating. As Dr. Kim was saying, so my job, I'm probably about 75% of my job, I am a researcher. And so in those roles, I am working on two main projects with two main lenses that I think it's important to share with you all because it does set the context for my work and how I'm going to present today. And so my work has focused on, I would say, disordered eating and how it shows up in the context of chronic disease. And so as I've been working my Career Development Award, as part of our work, we are developing digital treatments for binge eating that can be used in primary care for Black Americans and those experiencing poverty. We also are looking at how binge eating shows up in type 2 diabetes and how some of the factors that might affect binge eating and some of the things that may just kind of fuel this behavior and how we can help improve diabetes self-management education. So I loved working on both of these projects, and they really have helped me think critically about what are we going to do to help folks get eating disorder treatment when they may not come first to see someone who is an eating disorder treatment provider, right? Their first line of duty might be their primary care physician or their diabetes self-management educator. What are we going to do to make sure those people are equipped to be able to help and not do harm? I also am a proud social worker. And so my first job was a social work clinician at the University of Pittsburgh Counseling Center. I think it's one of my favorite jobs. I was just glad to get out of school. I had been very broke for a very long time. And I would say in that role, I was able to learn quite a bit about how to treat eating disorders among college students, but I also had the chance to see what eating disorders look like in the community. So I practiced after work, I would go and practice in different community settings and just continue to expand my knowledge with folks who weren't college students. And it just gave me some of my early questions about disordered eating because I would see people talk about it, but I'm like, well, they're not talking about, their pressure to be thin, or they're not they don't have that language. It's different, right? They might be talking about some of the other things, their trauma or food insecurity, and it gave me some early foundation to begin to form my research interest and to think about the lens that I was going to use when I came into the field. And so another thing that's important to know about me is I don't know how to work this PowerPoint. No. I'm sorry, you all. I'm hitting the wrong button. Okay, there we go. So another thing that is important to know about me is one of the questions of my work has had me think about how we can incorporate a health equity lens into our work with eating disorders and our treatments for eating disorders. And so I love this graphic because often, I think in our science, we have approached things with an equality framework, right? Just thinking about we give everyone the same thing. But we know that everyone is not starting at the same place. They don't have the same needs. And our treatments, we're realizing we're going to have to customize them, right? We're going to have to think about who is using these treatments and some of the factors that are affecting the manifestation of their disordered eating and some of their environmental inputs. Like we're going to have to think about that. And so if we're going to get to equity, we're going to have to realize that in order for everyone to get and go on their bikes and get to this place of health, as I imagine they're biking to, the bikes might have to look a little bit different, right? And we're going to have to think about our next generation of researchers are going to have to recognize that that is going to have to be a part of our science and to make room for that. And so it has been challenging, very challenging, but I have really enjoyed kind of thinking about what are we going to do differently? What do these populations need? What's going on? And particularly with Black Americans, what are we missing? And what can we do to really begin to meet their needs for disordered eating? So I am going to do a couple things with you today. One, I'm going to describe the prevalence of DSM-5 eating disorders and some of what we know about the challenges and access and treatment retention for Black women. And then I'm going to talk about the factors, relevant factors in the development of eating disorders, and then also what we're learning about strategies for culturally relevant assessment and treatment. So I always like to start with this slide because when it comes to us talking about eating disorders in Black Americans and other populations who we don't normally think of as having an eating disorder, I feel like some of these statements really kind of jump out. So one thing I have learned from my patients, from my research participants, is how harmful it can be because when folks don't believe this third one, eating disorders can affect anyone, right? Anyone. And often I remember when I first learned about eating disorders, and I don't know if anyone here remembers the after school specials. I don't know if I might be dating myself, but I'm an 80s baby. And so the after school specials, we would have often a cisgender, someone from an upper middle class family, a girl who was navigating either anorexia nervosa or bulimia nervosa. And often she was white. And so that is the picture that I remember learning about. Okay, wow, this is what an eating disorder is. And we would look and I remember in our communities, we would, especially in my community, we would think, oh, we don't have eating disorders, right? This is not something that we struggle with. And it wasn't just us thinking that, it was also other professionals thinking the same thing because we had an image of what an eating disorder looked like. And so also you cannot tell if someone has an eating disorder by looking at them. I know you all know how harmful that has been to the folks that we serve, right? It's how we can believe that we can determine this. And though there are behavioral and physical things that we can observe, because we have this stereotype in our minds, we have missed folks with disordered eating and we have hurt and we have done harm, right? And so, but the one that gives me the most hope, it is possible. You all know this, and we fight for this, right? To really keep this in the forefront of our hearts, knowing that sometimes we are navigating some really tough stories, really tough experiences with our patients, but we are hopeful, right? That we can recover from an eating disorder. And so that anchors me and continues to push me forward. So this image, right, as I talked about the after school specials, who struggles with an eating disorder? This is what I feel like one of the major barriers in my work with Black Americans, both with my patients and with those who serve them, is because this image is in our minds of who struggles with an eating disorder. And because we see this, we often aren't prepared when the reality of what we know and what we're learning in our science is that we all are susceptible to struggle with disordered eating, especially in our current food context, right? We all have the same water that we are navigating, at least here in the United States, the same water. And so some of the things that have affected us, though there are differences, there is an environment that is ripe for the development of disordered eating. And we are seeing that. And so one of the things that I am hoping, to be able to just lay a foundation for in my work is to help push us for and join the team of scientists and investigators who will show a different image, a different picture of who struggles with disordered eating. And so one thing I've been learning, and so I'm going to just give you all a little primer of what I've been learning in the science of where we're at. And so what we know in our science, and before I begin, I recognize you all might be like, well, it looks different clinically. This is not what I see clinically. And so I invite you to share, because often as the researchers, we are behind in some ways from the clinicians, right? We don't always have the latest information, but I'm going to share what we know in the science. And again, please let me know what you all think. So binge eating disorder, what we know is it's the most common eating disorder in the United States. And so we know that in 2013, binge eating disorder officially recognized as a formal diagnosis. And these stats, I always laugh because we know, you all know, these stats are not accurate, right? These are some of the folks that they've been able to get to participate. Well, we know most people who have binge eating disorder aren't going to actually get treatment for binge eating disorder. And they're not going to maybe even know that they have binge eating disorder. So we are cognizant this is an uphill battle, right? And we want to make sure, but to know that I think most of our science would show that anorexia nervosa is actually the most common eating disorder. That's what our science base would demonstrate just by the sheer weight of the research. There's just way more research on anorexia nervosa. But in reality, binge eating disorder is what we are navigating more often in the folks that we get to serve. So I've recognized that, again, most of our folks coming to with binge eating disorder, they may not be coming to specialty eating disorder clinics, right? They might be showing up in weight management spaces. They might be showing up in other cardiovascular health spaces, chronic disease spaces. Like they might be drawing outside the lines. And so it challenges us, right? Because if they're not coming to us, how are we going to be able to help them? And those are questions that I have been thinking about and grappling with in my work. And so what we know beyond the stereotypes, right, across racial and ethnic groups, binge eating disorder is also the most common ED, and rates of binge eating might be similar or higher in racial and ethnic minorities as compared to whites. And what we're seeing, I say this in the last 5 to 7 years, maybe 10 years, this food insecurity. We are learning far more about how food insecurity might impact disordered eating, and recognizing that those who are at the highest levels of navigating food insecurity, they have higher rates of binge eating and eating disorder pathology compared to those who are not. But when we look across racial and ethnic groups, I think we're learning just some things that I think is helpful as a foundation for our work. So a couple things. One, risk of anorexia nervosa is significantly lower for non-Hispanic, Black, and Hispanic adults. That is not capturing atypical anorexia. That is not, they're looking at and I think one of the reasons why it's significantly lower are, the presence of significantly low weight, and that requirement that has been a part of this for so long. We also see no racial differences in the prevalence of lifetime and 12-month rates of bulimia nervosa. And what we see is rates of lifetime binge eating disorder are significantly lower for non-Hispanic Black adults compared to other racial and ethnic groups. Now, this is one study, and what I would say, the data is mixed, right? This data comes from a large prevalence study, but we recognize we are missing pieces, okay? So, but we also see, this was another study that when we looked at the differences, like some of the other differences across racial and ethnic groups, Asian Americans had significantly higher than ideal internalization than African Americans and white Americans. And African Americans had higher BMI than Asian Americans. Okay, so those were the only two significant differences racially when we looked across eating disorder risk factors. There were no significant ethnic group differences with thinness expectancy, body dissatisfaction, healthy eating, dieting, overeating. Like you see this list. So the bottom line, and I don't know if we recognize this in how we're approaching our practice and our work, is that there are more commonalities in eating disorder prevalence and risk than differences across race. So what we're recognizing is that, okay, so we might have, if this is the commonalities are more present, then that means there's no one group that is more susceptible than another group to developing disordered eating behaviors. And we're going to have to think critically about how we're going to shape a practice and research landscape to adequately deal with this reality. So what we know is eating disorders are growing, right? They have been increasing at significant rates. This was over the last between 2000 and 2018. And so what we know is that from this time point, the prevalence of eating disorder diagnosis has increased from about 3.5% to 7.8%. And this is before COVID-19. So we know that with COVID-19, things really increased. So and I think this is an opportunity because as eating disorders have increased and more folks are impacted by them, right, we have an opportunity to begin to prepare to receive them in our treatment spaces. So when I think about Black Americans, there's some things I have been learning that I think I want to be able to provide to you all as some of the things that are the backdrop, right? They set the foundation, some of the cultural factors, recognizing that Black Americans are not a monolith, so everyone is not the same, but there are some cultural factors that I think are important to be mindful of. One, often, and this is something that we have used to say, oh, this group doesn't struggle with disordered eating because there are alternative views of weight and shape, right? This is something that we have been saying for many years. I've seen this numerous times. And so that is true. There is less emphasis on the thin ideal, but that does not mean that there aren't body image standards that folks are navigating and feeling pressured to meet. There's less emphasis on the thin ideal, but there are still pressures, right, to look a certain way that motivate and encourage and kind of push people towards some disordered eating behaviors. We also see that eating disorders may develop as strategies often to cope with negative affect, with stress. And so it may not be related to body shape or but it might be a response to trauma. We also know that there's often lack of eating disorder awareness. And often in my research studies, I am often for the first time, as I am really doing an evaluation, determine the extent of someone's binge eating in the study, what we are seeing is that usually the participants are like, oh, I just never knew, right? I never knew. And one of our first steps is to provide psychoeducation on binge eating. And it's something that people get help and support for. It's also important to recognize the historical relationship to food that has been a part of this community. And so we know, again, here in the United States, historically, this group, his slavery was often their introduction to this nation, right? And so they were in environments where there was extensive food insecurity. Folks did not have enough, right? And so there's a trauma that develops historically in response to not just history of not having enough. So whatever you had, right? Whatever you had, you were gonna make it into a beautiful mosaic with pride. And so we see there is so much pride that has been developed. And Black Americans in this nation have made new cuisines out of things that others would have discarded and not eaten. But because that's what they had to eat, they made, a very creative people. They made it into something great, right? And so, but then you also have to um, align that with how our food context shifted, okay? And how all of a sudden, as we shifted from more whole foods to processed foods and cheaply made foods. So we have a combination of deep love and respect and honor for food and joy with food and a food environment that has become increasingly toxic. And the combination of that has been very detrimental to Black Americans. And so they are navigating higher rates of chronic disease risk. And so some of these things are what kind of has been the forefront and not recognizing how disordered eating has been in the background and has played a part in all of this. And we are learning more and more about it. So we know that there are other big factors, right, that are contributing to disordered eating outside of the thin ideal. And so I'm going to just take a little bit of time and walk you all through our science and what we know about how these items, stress, racism, food insecurity, trauma, depression, strong Black woman syndrome, how are these affecting disordered eating and what we are going to do about it. But first, I'm going to show you all a movie, and I hope it works. Please let me know if you cannot hear.
As a Black woman with anorexia, it's a different experience because I not only have to kind of deal with all the eating disorder symptoms that are already there, but I have to deal with how it relates to my racial identity. Knowing that my body as a Black woman is never going to look like a white woman's. I am not going to be underweight due to muscle mass and bone density. And so having all of the symptoms of someone with anorexia and really struggling, but sometimes not getting treatment because I'm not underweight, so I can't be admitted places or have an official diagnosis. Or if I do have the diagnosis, still feeling so much denial about it because I have a voice in my head telling me that I don't have this or that I'm not sick enough, I'm not thin enough to be anorexic, but also having the outside world not really be able to see it either. It feels isolating. It feels isolating knowing that this isn't something that a lot of Black women have shared their stories of having anorexia and being somebody who deals with that. It feels like I'm sort of in between, like I don't get to be a Black person, but I'm not a white person either. I just kind of am stuck in this lonely place. And I'm not really sure where to go from there. When I talk about it in treatment, most of the doctors are white, and so they don't really understand what it's like for me from a cultural perspective. They can be educated about it, but truly getting it, to find somebody who really gets it, is hard. So it just feels very alone. I would say to treatment providers and clinicians to not assume that because somebody looks a certain way that they have a disorder or not. A lot of the time, Black women it's assumed that they don't have an eating disorder. Anorexia, bulimia, binge eating disorder, it's not even screened. So I would just say that to remember that eating disorders don't have a face, they don't have a representative. They can be in anyone, and they don't discriminate. And so in the world of treatment, we shouldn't either. We should look at it, the diagnosis and the eating disorder, for what it is, and see that it can affect anybody, and treat everyone who has them, because everyone deserves help. Everyone deserves to be seen, no matter the body that they're in or the skin color that they have.
Whenever I watched this was these vignettes, I would say we created them at Seed at UNC. And these were our students who had, navigated their experiences with disordered eating, were aware of some of the issues that were being navigated. And so they wanted to provide voice. And so every time I listen to this, it helps shift me and bring me back. Real people navigating real issues, and we are compelled, right, to be able to do what we can to make their treatment experiences better in the future. Whoops. Okay, hold on. Okay. So first thing, poverty. Wow, this is, I think, the new kid on the block when it comes to our recognition of how poverty influences in food insecurity influences someone's risk for disorder eating. And so we know in the United States, about 88% of the families are food secure, right? And so for 11% who are navigating food insecurity, we have a group that has very the group that we're most concerned about are those with low food security, so that 7%, and then the red triangle are folks with very low food security. And so what we know in this red triangle group, these are families who children are going hungry in the home, right? And so we know that in these families and what these families are navigating, the risk for disordered eating, and so both of them, low food security and very low food security, are associated with binge eating disorder. And but those who had the highest levels of food insecurity, they also endure significantly higher levels of binge eating, overall eating disorder pathology, weight, self-stigma, and worry compared to those who had lower levels of food insecurity. We're also recognizing the role of the SNAP benefits and the cycle that folks receive them. And so before it was SNAP, we called it food stamps, right? And what we see is that, and we have talked to folks in my research studies who are SNAP recipients, and what they confirm is that there are about 3 weeks of the month where there is enough food to eat, right? The SNAP benefits have support, like they are able to have enough food, but for that 1 week, that is a period that the benefits usually run out and access to food can be limited. So people are skipping meals. They're trying to, just do what they can to make it to the beginning of the month when their benefits are restored. And so what we know during this time is that as folks are navigating this cycle, that they restrict, and then once the benefits are restored, they have likelihood of binge eating, right? So we're seeing the same cycle develop, again, not necessarily related to achieving the thin ideal, but as a result of poverty. And we're recognizing the body has a response, right? When we're not getting enough food to eat, no matter what the cause of that would be. We also recognize the role of trauma and understanding how, and you all, of course, know this, but we're seeing with Black Americans how experiencing trauma and maltreatment in childhood is increasingly recognized as a risk factor for the development of DSM-5 diagnosed eating disorders. And so whether it was physical abuse, sexual abuse, emotional abuse, we've seen that is an increased risk for the development of bulimia nervosa and binge eating disorder. And for those who have maybe previously, there was a study where they were diagnosed with binge eating disorder, and what they saw is in these participants, the rates of emotional abuse and emotional neglect were reported at higher than 50%. Okay. We also see that racism, discrimination, microaggressions, these things, we haven't always thought of them as major components, and maybe had the language, but we know that especially among Black Americans, they are navigating these, and these factors have been shown when folks have had more experiences of racism, more microaggressions. You think these are stressors, right? They're carrying these stressors. We see higher rates of binge eating, disordered eating. We also recognize that those who are experiencing a culture stress, so let's say it's someone who identifies as Black and they might be in an environment where they're the only Black person, right? One of few, and they are in a majority white environment. We see that sometimes the thin ideals that might be endorsed by the dominant culture often influence these individuals, and they are navigating some of these pressures, right, to assimilate and to show up similar to some of their other colleagues in their communities. And we see that stress, that culture of stress, can also be a factor that's affecting disordered eating. We are learning more about the strong Black woman syndrome. And so that is just a group of behaviors where Black women might have difficulty accepting help from others. They might need to be independent. They may feel like they have to do it all, might, just try to carry the weight of the world on their shoulders. And so that's something that has been identified with Black women in our American context. And what we see is when there's greater internalization of this strong Black woman ideology, it's associated with emotional inhibition and regulation difficulties, eating for psychological reasons, and ultimately binge eating. And so I'm going to take you all through just some of our latest studies, what we've seen, and just to help you all, again, we're trying to put the pieces together, right? Trying to understand what we need to know to be prepared as clinicians to be able to support this population. And so this was a study done in individuals who had presented for treatment for, it was DSM, they had DSM-4 diagnosed binge eating disorder. And so these researchers looked across the races to understand the onset, right? And what was happening and what were the ages. And so there's some things that are interesting here that I'm going to point out to you all. First of all, let me give you a primer on the colors. So blue is the age of onset of obesity, yellow, age of onset of dieting, green, age of onset of binge eating, and then orange is the age of onset of binge eating disorder. And then they went to treatment, okay? And so, and this blue line is them currently in the study, all right? So you see, and this is, I think, interesting to see how for so many folks who were in this study, they had, even though it may not have been the same duration, they had a familiar pattern to how their binge eating developed. And first it was a response to them having more weight than they wanted to carry, right? And I imagine, again, we know our American landscape, folks were encouraging them to lose weight. And so you see it goes on a path. One thing I think is important to recognize when we look across the races, is just to see that the age of onset for dieting, it's different, slightly different across the races. And what we see with Black, and Hispanic, there's a quicker, trajectory to jump over to binge eating disorder than when you see with the white participants in the study. We also learned that when entering treatment, Black Americans present with higher BMI, but they have similar weight, shape, and eating concerns and similar or more frequent binge eating episodes. So this was a study that looked at folks who were diagnosed with bulimia nervosa. And what they saw is both of them, okay, so Black and white participants diagnosed with bulimia nervosa, they had the same, roughly, no real, significant difference in objective binge eating episodes and subjective binge eating episodes. But what was different is the compensatory behaviors that they noticed. So among the white participants, they were significantly more likely to do self-induced vomiting compared to the Black participants. And both groups were likely to misuse laxatives. So again, just think, if you are not aware of that information, it might disadvantage, when you're talking to your patients, you're talking to your clients, you might miss, just being able to screen and, they're not maybe they don't have bulimia nervosa, right? You might miss that, but they might prefer a different strategy. So it might be important to just make sure that you are, being able to assess thoroughly, because there are some racial differences in which a strategy folks are more likely to use. And so I now want to talk about what we have learned about COVID-19 and the impact of COVID-19 on eating behaviors. And so we are now coming out, right, of this time period, and it feels like we're still in it, but we are transitioning out of COVID-19, and it forever changed us. And I think it forever changed how folks navigated eating disorders and what happened. Often in this time period, what we saw is folks having to transition to virtual treatment. I think that's one of the biggest things that happened in COVID-19, that folks were used to going in person and more people had to go virtual, and to see how the impacts of that and how folks navigated their experiences with disorder eating and what they expected for treatment. And so what we learned, so this was a study done in the first year of COVID-19. My colleagues and I, we were looking at the impact. We did several studies where we're just navigating what happened for folks who had either past ED or current ED, like what happened. And so what we saw was that, and this was in the United States and the Netherlands, okay? And so what we saw is that folks were navigating, particularly they were navigating more restriction, engaging in compensatory behaviors. They were navigating, being anxious about not being able to exercise. These are things that had been challenging. When we look at just kind of a model of what was going on, why we saw the increase in eating disorders during COVID-19, what we recognized is one, it was a couple things. So we see that folks were home. We remember what it was like. We were home. We were exposed to more media. Our daily lives were impacted. We were isolated, right? We weren't sleeping as much. We weren't doing the things that we normally do. And we were anxious. We did not know what to expect. So we know that that risk also combined with lower protective factors, right? The social support was not what it used to be. The emotion, the ability to use the tools to emotionally regulate weren't always present. And folks didn't always have access to the treatment and the care that we need. And so we have learned, right, that both of those things combine to increase the risk in eating disorders. So when we think about for Black Americans, my team and I, we did a study early in COVID-19 among Black women who reported binge eating episodes to see what did we learn, right, about the impact of COVID-19 in this population? What were they facing? And so our sample on average is about 43 years of age, about a college educated sample, and they were reporting about a little over 5 on average, objective binge eating episodes in the month, okay? And they weren't doing much purging. And so what we saw are several themes. They were navigating an increased time in a triggering environment. So again, similar to what we heard other folks navigating, a lack of structure and routine, and then the increased episodes of loss of control eating, limited food availability. And the thing that I think was maybe more cultural is this use of food as a coping tool. So one of the participants said, I find myself eating ice cream and cookies 2 or 3 times a day and at bedtime, which are things I never did before COVID. Okay, before COVID, I could eat a bite of any dessert and be completely satisfied. Since COVID, I have wanted to eat the whole dessert. That's different. That's very different. And I have been this way for years. When it came to dessert, 1 bite, enough, satisfied, done. Since COVID, I'm not satisfied with anything. And God, it feels like I'm never done. Other participants talked about food as a coping tool, and just recognizing how they can't do what they want to do. They can't, so they eat, right? And so when we thought about, again, just a model of what we noticed in how COVID-19 impacted Black women who are reporting binge eating, we see that this use of food as a coping strategy and increased eating due to being home, the food we stockpiled. This was during when we had quarantine. This is kind of right at the beginning, right? And so a large amount of food was easily accessible. The structure and routine had changed. People were staying up later than normal. And then food availability was challenged, right? Folks were increasing their purchases of non-perishable items, eating more refined food. And what we noticed is that we believe this was a pathway to increased lack of control, increased binge eating episodes in this population. And so when we think about just in treatment, what we know is that Black Americans, they're less likely to receive treatment for disordered eating, okay? They are more likely to drop out of treatment. And so we start to wonder why, right? I think whenever you see this data, you should wonder why. What are some of the things that are impacting this? What are some of the, and so I'm going to tell you a little bit about what I think might be going on. One, I think this study was one of the early ones. Kathleen Pike and her group were looking at disparities, what we were learning, early disparities in eating disorder treatment access. And so what they noticed was that among the pink is the white women bar and the gray is the Black women bar. And when they looked across these races, what they saw was that both groups are equally as likely to get treatment for a weight problem. But white women were 3 times more likely to get treatment for an eating problem, okay? And so and I think it's just, they were just more likely. And again, I think it's some of our culture, right? Who we believe has eating disorders. And then that trickles down, folks knowing the resources to access eating disorders, folks thinking that the problem that a legitimate problem that they're having. Like it's complex. But I think this gives you an idea of kind of, even though the study was done in 2001, I believe that it still bears relevance on what are some of the things that we're recognizing in disparity in treatment access. I think we're also seeing that, and this was a study of lifetime service utilization navigating eating disorder. And so we saw that for the white participants, they had significantly higher rates of service utilization compared to the multi-ethnic populations. We also see when folks were sharing, this was a qualitative study where they were asking multi-ethnic women, why aren't you seeking treatment for eating disorders? And so what they saw in the sample is financial difficulties were some of the number one reason. And I would say, again, we've had some studies that were just published, and that was probably high as well, financial barriers. Also, just shame, discrimination, fear of being labeled, these things still matter. And I believe that there's still some of the reasons why we see some of the disparities in folks seeking eating disorder treatment. I also think, this was a question that I had seen in an article, and I had to stop, and it just kind of had me just stop in my tracks. And I guess I would ask you all the same question. Why aren't we paying more attention to eating disorders in people with larger bodies? Like, what is it? Why we say that they can affect anyone, all right? But we know that when you're in a higher weight body, you're going to be treated differently, right? You're going to experience this whole thing differently. We know that, again, for many, with the data, for many Black American women, there are some of the ones who are in larger bodies, okay? And so they are having some of these experiences. And we know weight bias is, it's a major thing that folks are navigating, okay? About 54% of adults with obesity report being stigmatized by their coworkers. Nearly 70% of adults with obesity report experiences from weight bias, from a healthcare professional. Like, these things are in the background. And so what we know is that some of the reason that I think some of this is happening, why we're not paying attention to folks in larger bodies, is one, over-reliance on BMI, right? We have used that metric, and we all know about some of the flaws with BMI. And our clinicians are trained and might only perceive eating disorders as anorexia, perfectionism, preoccupation with the thin ideal, and they might miss other risk factors. Like, what they recognize in the study I cited is that the year before someone gets treatment for binge eating disorder, they might experience rapid weight gain, okay? And so that is something that they're recommending that clinicians look for when they're trying to understand if someone might be navigating disordered eating, but that is not something that folks always know about. And if the patient meets BMI criteria for obesity, our clinicians are way more trained to talk about weight loss and risk for type 2 diabetes. That might seem like what they need to be talking about. And so we are kind of navigating this landscape as we speak. This is the reality. And so eating disorders in higher weight bodies are going missed. And if you are a people group who are in a larger weight body, you may not get your support for disordered eating. And so this was a study that was looking at adolescents who are presenting for eating disorder treatment, okay? And so about 37% of these adolescents had overweight or obesity. And so those who were, if they were overweight, their diagnosis of eating disorder was delayed by 9 months. So what we're recognizing is with weight bias, folks aren't always looking at, they're not screening for disordered eating, and they might be missing it. They might be celebrating, oh, that you lost weight. Oh my goodness, congratulations, that's wonderful. And not recognizing, not realizing that there is disordered eating behaviors, right? We're not asking, we don't know to ask. And folks are being, having delayed care. And so it's giving more time for the disordered eating behaviors to worsen and not to get the support that they need because of our weight bias environment. And we're going to have to really work to do something about that. So this was, I think when we also think about some of the challenges with eating disorder treatment and what we hear from clinicians, okay? And so this was a study of the perspectives of therapists of color that treat women who are experiencing eating disorders. And this was in the United Kingdom, but I chose to highlight it because it really, I think, still bears witness and it's relevant to what we're navigating here in the United States. And some of you all might be feeling this way. And so what they noticed, okay, these are the therapists, shame is a barrier, okay? They felt that their clients were navigating shame, okay? They didn't have a lot of family support, and they didn't even always have the language, right, to say it, to share with their provider about their experiences with disordered eating. The therapists were also feeling restricted. They wanted to do more, right? They wanted to offer treatment for the diverse populations who were navigating disorder eating, but they were nervous, right? They were afraid that they were going to get it wrong. They were going to make a misstep and they didn't really have time, right? You all I know are in the streets right now, just you're busy. When you are seeing clients full time, you often don't have a lot of time, right, to reflect. And these therapists were navigating it. They also were working with cultural difference, okay? And so they were understanding, how eating disorders, that they might show up a little differently, right? And they're recognizing acculturation is real, okay? And trying to be curious. And I think that's often can be one of a great starting place, right? Just to be curious about the difference in front of you and to be willing to go in there and look into it, right? And navigate it and understand it a little bit more. We also see, again, some of our bias is one of our challenges with some of our clinicians, because this was a study that was done in 2006, but it's one of our, historical studies that when these are psychologists and they were presented with identical case studies demonstrating disordered eating symptoms in white, Hispanic, and Black women. And so the clinicians were asked to identify if the woman's eating behavior was problematic, okay? And so 44% identified the white woman's eating behavior as problematic, 41% for the Hispanic woman's eating behavior, but only 17% were able to identify the Black woman's eating behavior as problematic. And so just know, like, this is what we are kind of navigating, what we're dealing with. And so I went over this before. So now I want to go into, okay, so what do we do, right? What is it going to look like in treatment? How might I begin to, thank you for the research, I know about it, but I'm a clinician, okay? And I want to be able to do some things in my practice, in my treatment space that will help these patients, right? And to be open. And that's what I want to present to you. So one of the first tools that I would encourage you all to consider if you are really wanting to work with Black patients navigating disordered eating, there's this book, I'm just gonna jump in my, there's this book called Treating Black Women with Eating Disorders, A Clinician's Guide. We call it the Purple Book, affectionately, by Charlene Small and Mazzella Fuller. And this is, I think, one of the only books that kind of brought a compilation of different clinicians and therapists to share on their experiences with treating disordered eating in this population. And so it's a great resource to have as you're trying to kind of understand the lens that this population might have, right? And so one of the first things that they pose in the book is we think about your questions, right? How are you assessing? How are you gathering information on disordered eating? How are you even framing your assessment questions and thinking about, are there things that you never ask about? Because you probably ask everyone the same thing. And so to think about, like, when you look at these questions, right, and you read them, just think about, are these things that I ask my clients? Are these things I ask my patients, right? What is most important to you about your culture or ethnicity? And what influence, right, has race, class, hair, it played in shaping your body image? What has it been like for you growing up, in a culture where you're experiencing racism? The messages about food that you've received, and oppression, experiences of oppression that your client might discuss. And so often what I've heard is that you're not always used to being asked these questions, but I think it can be a real opportunity because often the disordered eating is connected to some of these things, right? And so if you're not creating the space to assess and ask these questions and really allow your client to bring in their racial and ethnic identity in other ways, I think sometimes we think, oh, they'll bring it up if it's relevant for them. But sometimes, especially if it's, a provider who does not share our racial background, it's something that you have learned to not talk about, right? You have learned to only talk about it with those who you assume will be able to gather. So they may not bring it up. And if you don't ask, then you might be missing some things that might be playing a big part in their experiences with their eating, okay? And might be shaping some of their behaviors, okay? So when we think about in this population, a comprehensive assessment, we're going to add a couple things, okay? Recognizing, in addition to understanding the history of eating patterns, right? We also want to understand the cultural implications of food. What did it look like for you in your community? How did you relate to food growing up? What messages did you receive about food? And whether they might be navigating a culture to stress, are they like one of the only Black ones in an environment where that is stressful, okay? And so give them room to talk about that, and it might help you gather more depth on their eating behaviors. Food insecurity. I think more and more with our science and what we're learning about the role of food insecurity, more and more clinicians, I think, are recognizing we have to make sure we're asking about this and asking if our clients have enough food to eat. Trauma as well, other comorbid conditions, navigating particularly chronic disease, and then a comprehensive assessment. I feel like, you almost can't go any deeper than you're willing to meet yourself, right? That's kind of how this works. We know this how it works in our clinical work, but when it comes to when you're crossing over racial lines, often the work is harder when we haven't done our own self-examination, right? Of our own biases, our own beliefs. And so if you haven't done that process, it'll feel like a lot more awkward, right? To walk around and talk about that, even to acknowledge, right? We have a racial difference in the room, like to bring that in and give space if the client will want to talk about it. And so if that's not something you've really done with yourself, then it's going to make it a little more challenging for you to want to do that and even have the language to do that with your client. So your process, where you are, your own individual journey, your own self-examination, it matters. And we know that, right? But it matters. It really does matter. When we think about what we know about our treatments for disordered eating, so in our interventional space, before I do that, I'm going to go to this other slide, okay? I think it's also important to think about cultivating an intersectional understanding of your clients, okay? And to know that I think often we focus on one demographic element, not always understanding how they all intersect. And if your client is having several marginalized identities, we know that there are likely going to be greater impacts when it comes to disordered eating. So your client might identify as being Black, but they also might be experiencing poverty, right? They also might be a member of the LGBTQIA community, right? like as these intersections, like as they multiply, we see. And so if we think about our clients in that way, and sometimes I think we focus on maybe, we haven't thought of them as intersectional and how the intersections often create challenges, and they make things difficult. And so to really begin to cultivate that. Also, when we think about what we know about our treatments for eating disorders, I think that there's the most evidence on cognitive behavioral therapy, enhanced CBTE, which I know you all are familiar with. This is our gold standard. But again, when we say there's the most evidence, none of these treatments and none of our science has really begun to tell us about how Black Americans participate. And again, what we know is that when they're in treatment, they are more likely to drop out. And so again, we don't have the science though, to really begin to understand all the reasons why, and all that's happening. Sometimes we've heard folks say that there is a mismatch with their clinician. They might think, oh, I'm doing better. I don't have to keep coming. It might be financial difficulties, like I said before. But what we know are like, these are some of our main treatments for eating disorders, but, and again, based on the science, but we also know that we don't know enough about how they impact Black Americans and but I think we know enough to know that I think as the clinician is sensitive to their experiences, that you can, and you're creating, I think that clinician alliance is going to be a major factor. And all of these treatments might be potentially beneficial. Like we do know enough to know that there's not a lot of racial differences in some of the treatment outcomes, but we just don't have large enough samples with Black Americans, and other populations of color to really, really have confidence, I think, in knowing that. And so that's part of our work, right, is understanding how these treatments really begin to impact others and what can we do to offer help to support our clients. One thing that I've been increasingly interested in is the role of digital health, right? And I'm so grateful we have more digital health treatment spaces, right? Reducing barriers and giving folks the opportunity to get help. I think it's great. And I think it's a great direction that we're moving in. And I'm hopeful that it's going to be something that is going to help us. And so we also, oops. Okay, we did that. So when I think about the level of intervention model for Black Americans and what we need to know, one thing I think that's important is on the individual level, when you're working with your clients, you might have to provide, they may not know about eating disorders. And so they might have limited information. And so it's going to be, I think one of an intervention is psychoeducation, and also due to the historical relationship with food and its emotional and how it's been a source of coping, right? It was the mental health treatment. I feel like there's enough science to know before Black Americans were going to therapists, they were eating. That was their mental health treatment. And so recognizing that there might be higher rates of emotional eating, these things might be unaddressed and just kind of inadvertently might be supporting disordered eating behaviors. And so to help them have increased awareness of alternative coping skills for those negative emotions and for providing support for the stress, the racism, trauma, the microaggressions, right, on an individual level to provide support for those things. Then when you think about from the family aspect, is really being able to explore with your client and helping them understand the meaning of food and just what it has been historically in their family, right? What messages they received and the expectations that they had for eating behaviors, and to be able to help them define what they want it to look like now, because there might be a separation. And do they have a history of food insecurity in their past, in their background, and to be able to assess, because if it was there, if at any point they were navigating experiences where they did not have enough food to eat, that trauma does not go away, and folks carry that with them. And they can build their whole life around never having to experience that trauma again. We also recognize our providers, right? We have to help them increase awareness that eating disorders, it may not be related to the over-evaluation of shape or weight. I think that's one of the things that we have learned most about this population. It may have nothing to do with that. And how the impact of stereotypes have been so just so shaping for this group, and how we need to continue to think about what our trainings look like and what are the norms in this group of disordered eating. And then I think on a system level, it's thinking about, and this is what I have fun doing as a researcher, is thinking about, okay, well, where else are we going to be offering treatment for eating disorders? Okay, and to think about in community settings, in primary care settings, and think about what assessment tools that we use for eating disorders in programs where folks are going for weight management. And I know that we can be, kind of a tense subject among eating disorder clinicians, but the reality is that our patients often will go to weight management first before they will come to the eating disorder clinic. And so how we can support our weight management clinicians and help them be able to have the tools so that they are able to assess for eating disorders before they might refer someone to start medication, right? They're able to screen for eating disorders and have the tools that they need in order to do this. So again, what we know is there's just limited evidence on treatment trials for eating disorders in Black and Brown populations. And so we know the challenges with service utilization. We're going to have to make some changes. So even though we know that it's likely some of these same treatments that we've used that have been impactful to treat eating disorders may probably help these population in the same way, we're going to have to think about where we're going to offer the treatment, how we're going to get them to participate, and how we're going to incorporate their culture into our treatment spaces. We know that there's similar prevalence of eating disorders across racial and ethnic groups, but we also know that there are disparities in access and retention to treatment. And we have learned about poverty, racism, a culture of stress. Those things might also contribute to the development of eating disorders. And so we're going to continue, and I, as a researcher, I've taken up this charge, right, on different strategies to reduce disparities in eating disorder treatment and access for this population, and to examine the prevalence and the nature of eating disorders in other populations so we can understand the differences in treatment response. So that concludes my presentation. And now I'll open it up for questions.
That was awesome, Dr. Goode. Thank you so much for being a leader in the eating disorder world, and for being willing to share your research and your expertise with us today. So anybody who has questions, drop them either in the chat or in the Q&A box, and I will get started with a couple that I have. First of all, it was so refreshing to hear you even just start with, a couple of different times in your presentation, you mentioned, our whole evidence base, when we talk about evidence-based care in the eating disorder field, is overwhelmingly based on predominantly white, thin, middle to higher socioeconomic status people. And when you talked about the community-based work that you were doing, people weren't talking about this pressure to be thin, right? And you also mentioned, it's not, I think there's this myth that is still very, very prevalent in the eating disorder world. I mean, even if we look at our DSM criteria for eating disorders, all of them have as a necessary criteria overvaluation of body size and shape. And I've treated plenty of people who don't have that. I'm recovered from bulimia and food addiction, and grew up on back when they were called food stamps. And I knew coming into the eating disorder field that there was more to the story than that, just from my own lived experience. But there's so much, it's like this force that's just like inertia that's this is the focus, this is the focus, this is the focus. And I think one of the things eating disorder clinicians often say or think is like, well, if it's not related to that, then what could it possibly be? Right? So any thoughts about how to respond to that question, and more so how to, you know, overcome this sort of like invisible, powerful force to like, let's keep focused on this and silence all of these other discussions.
Yeah.
How do we as clinicians, as people attending conferences, giving talks,
Mhm.
keep pushing the message that you shared today?
Hmm. Ooh, Dr. Kim. If I was with you, I'd be like, yes, Dr. Kim, yes, yes. I think so. A couple things. I think part of how when you know where you're going, you think you know where you're going. If you're out and about, you're walking fast, right? You're not looking, you're not paying attention because you think you know the direction. You think you know. And I think one of the biggest challenges to disordered eating, I think there's some place that we think we know. We think we've seen it. And I think because we are moving quickly, right? And we are not stopping to say, oh, that looks different. No, 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 we know. And so I think that's one of our biggest challenges is that we honestly aren't humble enough to recognize we have done all this research and yet we still got to go back to the beginning.
Yeah.
But what I think if we were honest and just said what we've done a lot of research on eating disorders in one particular population who's kind of showing up for one particular thing. Like we've done a lot of research in this one area. And so I think if we were just a little bit more honest about what our science really is, I think we could grapple with, wow, there's a lot we don't know, right? Wow. And so could create more room for people to begin to start designing research studies where we can actually gather those evidence. I think another challenge to this is that our pipeline, when we develop the next generation of clinicians, eating disorder clinicians, so psychology is the kind of they have most of the weight of when you think about who or how folks are getting trained to become eating disorder clinicians. You go through psychology training programs. But if you don't go that route, it can be hard, right? You have to do extra training. You have to seek it out on your own. So you already have a busy clinical treatment experience, but you have to do extra work. And so that means that then the clinicians, and we know psychology is overwhelmingly white, right? And so clinicians who often will get the support, the people who are going to ask about these other ways of showing up of eating disorders aren't always going to be positioned to be able to lead the research studies and get the training that's needed to really begin to ask these questions. So I think we have to think about how do we create an opportunity for so many more to get training on eating disorders so that they see themselves in these experiences, they see themselves and they're able to bring their experiences. So I know part of the reason that the studies that I do are based on what I saw as a clinician, right? What I saw. And I know there's so many others who are that's how a lot of us work, right? You see things that it piques your interest, and then you go and you ask questions about it. And so we got to just create a pathway for more folks to be able to have their story, for co-creation, right? To think about, so often we've created our knowledge from, the ivory tower, but wow, what if we think we know where we're going? We don't know. Let's just stop and ask for directions. Okay. We don't know. So if I'm stopping and ask for directions, who am I going to ask first, right? Our patients, our clients who are navigating
Yes.
this every day, right? Let's ask them.
But Dr. Good, they're sick. We can't ask
I know.
them.
I know. Why would we think? Yeah.
Right.
Like we have to stop. So it's hard. I feel like the hardest part is for us to stop and say, okay, we need help. We do not know where we're going. Can you help me?
Yeah.
Can you show me the direction so I could get where I'm trying to go? Yeah.
Yeah. No, I mean, again, so refreshing to hear a researcher from the ivory tower saying like, we don't know, and we just don't say that very much in the eating disorder field.
Mm.
But we really don't know,
Don't
you know?
know. No, and it's changing. As our culture changes, it changes, right? And we
Yeah,
have a lot to learn. We have a lot to
yeah,
learn.
yeah. Okay, here's just a comment for you. No questions, but absolutely wonderful presentation. Thank you for the abundance of knowledge and research. So
Thank
I'll share some of the affirmations coming through too. And this is a question from Lisa Z. Well, Lisa, I'm so glad you could be here today. Um, Thank you so much for sharing this. I work as an LCSW at a health plan, in part doing utilization management for higher levels of care. I've gone to enough trainings to be familiar with some of the information you shared about how eating disorders can look different in different communities and binge eating disorder being so common. I'm constantly advocating with peers and supervisors regarding improving days for care. My question is, can you share some information that will be heard by health plan higher ups indicating what levels of care are needed for binge eating disorder? And what criteria should be used for evaluating medical necessity for eating disorders? Because Interqual and MCG are biased due to their research being what it is, right? Having all the holes that you talked about it. It leads to stereotypical eating disorders being denied for care because the reviewer is afraid what the patient is experiencing doesn't match the Interqual, criteria.
Mm,
So that's the
mm,
first part of the question. So maybe have a
mm.
stab at that, and then I'll share the second part of the question afterwards.
Ooh, Lisa, I mean, I think first of all, thank you for your question. Thank you for your question and thank you for your work, right? You are in it. And it just breaks my heart because as I hear your question, it's like, okay, the insurance companies, they're not seeing the science to back up what you're seeing clinically, what you're seeing. And they're like, what are you talking about? They're not believing it. And I know there's so few scientists who are in this space, who are doing this work. I can think of maybe five or six of us who are, at least with Black Americans who are doing this space. And so it's so limited. And so to answer your question, if I'm being honest, I probably wouldn't, since I spend most of my time as a researcher, I don't know if I would probably have the best answer to your question because I don't think I have enough clinical treatment experience. When I think about what I've learned, but I'll tell you what I've learned in my studies. And so when I think about our current criteria for binge eating disorder, one of the things that has been challenging is that for Black Americans, there may not be distress present. And folks may not feel, because again, it may not look the same way. We also, I think the number of binge eating episodes and the subjective versus the objective, that can be challenging because I think what we know in our science is that even if it's objectively large or subjectively large, just the fact that the loss of control is present is what is so upsetting to our patients, so upsetting. And so I have learned in my research studies to hold less, to be like, well, that's not an objectively large episode, and less weight on the size of the eating, but to look at the impacts and to be able to highlight the impacts. And even if that over evaluation of weight and shape are not there. But I would admit, this is a challenging area. And I want to do all I can to help. It just motivates me to want to do what I can to help push our science forward so that we really have the evidence, right? That's our issue. We got to have the evidence there so that you as a clinician can use it and you can begin to do it and have the evidence that these insurers will need in order to make some of the changes.
Awesome. And then the second part of that is any thoughts on how to advocate with health plans regarding obesity drugs and binge eating disorder, social determinants of health, DEI? We're so focused on weight loss and stuck on BMI, it feels impossible to shift.
It does. It does. I think one of the biggest things that I would love to see is even just a screening for eating disorder. Like, that is something that is not, again, universally done, but to begin to at least offer that and make that something that has to be done, because we know that, again, folks are on these medications, they're not going to be on them typically over a year, right? So folks are going to get on these medications and they are going to get off. And it's often they're going to, we know that their hunger will be suppressed, but when they get off, the hunger is coming roaring back, and and that's not going to treat, right? The binge eating, the emotional eating, like all of the disorder eating, restrictive, like none of that is going to be dealt with. And so when the person comes off the medication, because it is typically they will be coming off for various reasons, when they come off the medication, they're going to be dealing with these same impacts and probably be heartbroken, because we know what it's like, right? When you're on a diet and you gain the weight back. So we're about to have more weight cycling, and people feeling more discouraged and more in despair than they've been before. And so I think, again, when we think about equity, when we think about social determinants of health, it's so because there's so many levels to how we're going to handle this. But one thing I think that comes to my mind is what would it be like if we had a treatment landscape where people were able to really get what they need, right, on all levels? You all know, wow, wouldn't that be amazing? That we really would prioritize folks' health. But again, because that's not how we do things, people are going to get access to medicine when they might really need something else, right? They might need another intervention. They might need another systemic intervention that might be better, or they might need additional eating disorder support. And my hope would be, again, at minimum, that we would ensure that everyone is at least screened for disordered eating before they're able to proceed with the medication. And we still prioritize clinical behavioral treatment to support folks as well.
Awesome. Yeah, I've seen patients, over the last year have the GLP med, feel like, oh, I don't have the food noise anymore. I can eat when I want, stop when I don't want. And then this week the insurance wouldn't cover it, or this week the pharmacy's out of it, right? And it's completely dysregulating for the person and demoralizing, as you said.
Demoralizing.
Um, and it's interesting too, but many insurance companies will not cover these medications for weight loss indication, but will
Right.
cover it for type 2 diabetes or cardiovascular risk.
Mhm.
Um, okay. Um, Great presentation. This is from Alice. Alice, I'm so glad you came, one of our therapists here in our Naperville location. Great presentation. I think Black women are often misdiagnosed, not diagnosed with an eating disorder, because white America sees Black women, white America and, predominantly white eating disorder professionals see Black women as Aunt Jemima, the mammy of the plantation days, house servants, cooks as portrayed in old movies, especially. These characters were all in large bodies. What are your thoughts about that?
Yes, they were all in large bodies and invisible, right? They were not seen. And I think that in essence, they're not even seen, like, and again, when I've talked to women who are in larger bodies, Black women who are in larger bodies, they often talk about, like, they're not seeing me, they're not hearing me. And there's something historical and in or we're not listening in the same way to these experiences and these realities, that are affecting Black women. We just don't listen. We can't hear them in the same way. We know we have the studies and the medical history to show that that's something that happens. And so I think what we're dealing with is that, oh, like I haven't even seen you. Like I haven't even really paid attention enough to really begin to help you in the ways that you need. And when you're telling me you need something, again, this water, I'm probably not going to hear it and think, I think you can handle it, right? You're tough, you're strong, like you can handle anything. And those things combine to create an environment that is so harmful and so deadly for this community.
Awesome. Yes, yes, yes. And you know, you mentioned, we don't listen to our patients. And in the eating disorder field, we operate in a very paternalistic way often in the ED field. Like you're having an experience about your body and your food that must be disordered based on you having an eating disorder versus, wait a minute, like maybe this is actually this person's experience and I need to listen to this and take this and co-create a treatment plan that incorporates the patient's voice.
Yeah.
Okay. Um, so food addiction. Food addiction is one of the areas of my interest and research that we're doing. And its association with higher BMI, type 2 diabetes, cardiovascular disease, food insecurity, corporate like food supply chain marketing practices, which target minoritized populations. So any comments on, the like, first of all, your thoughts on food addiction and then its connection to food insecurity,
Mhm.
binge eating, particularly among Black women.
Yeah, so I am a proponent. I believe food addiction exists. It is real. And one thing, again, you think about what we know is that the amount of ultra processed foods, again, the ones that are the most addictive have increased, right? They're increasing in the numbers that are on our shelves. And so we know that this is a landscape where folks are in eating things that are probably in this ultra processed category. So it's almost like they are even set up from the beginning, right? Because they're consuming these things in their diets. And again, it's so sad. We don't have enough science to really understand how we treat food addiction. I think we have some great measures, some tools, and I know a couple investigators, they have done some pilot feasibility work that I'm aware of where they are
We're
helping.
doing one.
Yeah. So you were part of the team, but thinking about, I, again, we haven't said this a lot, but I think for some of our treatments, again, this is just Dr. Rachel, my clinical experience, we might have to, um, recognize that moderation, for these ultra processed foods, that's the advice that we've been giving, right? Eat the things in moderation, but for these ultra processed foods, that may not be helpful advice, and they might be better off not having these things in their diet at all, and to begin to make aware. So I think that's one of the first things is that I don't know how well we have done at really we might make folks aware, but that we haven't supported them with the systemic tools, right? You might be aware, but this is all you got. It's all the money you got to afford X, Y, and Z. So you're going to eat what you have access to.
Yeah.
But I mean, what will happen if we actually loved our people and we began to support them? Again, at the individual level, we've made this issue an individual level, and it's really not an individual. People are just making the decisions that are kind of put in front of them. And we got to coalesce and start really using our power. Again, not to fight with each other because we're all at the same level. Like we got to go up and begin to fight. And get this environment in a place that can really facilitate our folks being healthy and whole, like, and to really get them what they need.
Yeah. Awesome. On the policy level, right?
Yes, on the
Like,
policy level.
why don't all people have access to some sort of balance of whole foods and hyperpalatable foods?
Yes. And you think about, again, for the parents,
Yeah.
in the room and these children and how much of a fight it is to try to fight. I feel like you are fighting so much for your children because for the moment they come out. It's sugar, 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 everywhere you go. And it's just so hard. It's so hard. And it feels like you're by yourself sometimes. That's how I feel.
Yeah.
I'm me and myself. And the kids are like, what are you talking about, Mom? This is great. And you're like, oh, yeah.
Yes. Yes. And I will just say that, what you just said is not diet culture. I think oftentimes this conversation gets silenced in the eating disorder world as like, stop talking about that. It's diet culture, and you're going to you might make some of the thin people with anorexia uncomfortable by talking about this. Um, okay.
Yeah.
One more quick question before we wrap up. Um, do you find that Black women with eating disorders talk about pressures inside the home, like by a mother or female figure? I do think body shaming within families is prevalent among persons of color.
I would agree. Yes, it is prevalent. It is prevalent. And we know what happens when we shame people's bodies. And how likely when folks have experienced that. And we know in our science that body dissatisfaction in itself is a predictor of binge eating in this population. So yes, so you're right on. And folks have experienced just there, and I think that's one of the studies that we were collecting some other data, but we have some stories from women when growing up in childhood and some of those childhood impacts. And so that's something that I'm hoping to get into a little bit more, is to see like what is happening in childhood. And again, if they were growing up in the 80s and like there was a lot of, that's how we treated people, right? We shamed them before we even knew. So folks had all these experiences related to that, thinking that that was what people needed to hear, but we know better now. But yes, that's a big problem. We seem to like talking about and commenting on people's bodies. I don't know why we think, I don't know why we think that's a good idea, but that seems to be what we do in our family.
All right. Well, we are right at the 12:30 mark. I just want to thank you again for just such an awesome talk. It's recorded, so it will be available for the next year. So feel free, anybody who's come, to share the link with anybody you think might benefit. The C and the CME will be available for a year too. And reach out to Tammy Gazer if any of you have any difficulties with anything. I want to thank you all attendees for coming today, my team at Suncloud for all the footwork that went into this, and happy Friday, y'all.
Happy Friday.
Bye, everyone.